All right. Thank you for joining us for today's CMS Measures Management System Information session, Strategies and Efforts for Improving Diagnostic Performance. My name is Aya Gunny, and I work for Battelle in support of MMS. This webinar is just one aspect of MMS education and outreach, and I invite you to visit the MMS Hub website to learn more about MMS and how to get involved in quality measurement. And we can go to the next slide. So throughout today's presentation, I encourage you to submit questions using our Q&A feature, which you're going to find near the bottom of your screen. We'll be addressing questions during the live Q&A at the end of the presentation. And then following the meeting, we'll share the meeting materials, including the questions and answers that we went through today on the MMS Hub website. And we can go to the next slide. Okay, so this is just showing you exactly where that Zoom Q&A function is. Please feel free to send in your questions as we start the discussion. And we can go to the next slide. So today we're very excited to welcome Dr. Sumant Ranji and Dr. Ben Rosner from the University of California, San Francisco Coordinating Center for Diagnostic Excellence, or CODEX. So Dr. Ranji is a national expert in patient safety with a particular focus on diagnostic excellence. He's a professor of clinical medicine and the director of CODEX. And we're also joined by Dr. Ben Rosner, who's a professor, faculty lead for the CODEX Action Incubator, a hospitalist, informaticist, and diagnostic performance feedback researcher. And with that, I will hand it over to Dr. Ranji to get us started.
Thank you so much, Aya. And I want to thank Battelle and CMS for the opportunity to present to you today about our ongoing work on developing measures of diagnostic excellence in the era of artificial intelligence. So Ben and I will be discussing our ongoing work, which is still in progress, and we're very excited to present this work to you today with the goal of helping everyone understand how we as a center are thinking about measuring diagnostic excellence, and we would also love your input on our work, which is in progress right now. So I'm going to start by giving a little bit of an overview of diagnostic excellence and discuss our role at CODEX, which is our UCSF Center for Diagnostic Excellence, and the role that we play in diagnostic excellence and trying to improve diagnosis overall. And then I will transition into discussing the work that Ben is leading with our Action Incubator, which is really centered around trying to improve the measurement of diagnostic excellence with a particular focus on diagnostic excellence in the era of artificial intelligence. So when we talk about diagnostic excellence, what we are referring to is the ability of a health system and the clinicians who work within it to provide patients accurate, timely, and equitable diagnoses while also using resources efficiently and managing uncertainty. At CODEX, we very much view the process of diagnosis as a partnership with patients. And as we'll discuss, part of our work centers around understanding how patients themselves can evaluate the quality of diagnosis and participate in the process of diagnosis. I would also emphasize here that diagnostic excellence is about more than just preventing diagnostic error. From a patient safety standpoint, diagnostic error, as I'll discuss, is a well-recognized patient safety issue that has evolved in different ways over the last several years. But when we talk about diagnostic excellence, of course, preventing errors is an important part of that. But we really view diagnostic excellence as more than just the prevention of error. It involves the achievement of, as I said, a system in which all patients are able to receive accurate, timely, and equitable diagnoses. The domains of diagnostic excellence involve accuracy of diagnosis. So was the diagnosis correct or not, or as correct as possible? But it also includes timeliness. So did the patient receive a diagnosis in a timely fashion in order to be able to benefit from appropriate treatment? And another domain that's very important is communication. Even if the clinician and the health system do everything correctly in terms of establishing a diagnosis, if that diagnosis is not communicated to the patient in a way that they understand and in a way that helps the patient understand both the implications of the diagnosis and the resulting treatment plan, then the system has failed the patient. As well as these domains, the use of appropriate resource utilization is very important, both from a patient standpoint, because inefficient use of resources can lead to financial toxicity for patients. And as well, from the health system standpoint, even if a diagnosis is reached by an inefficient process, that incurs great costs to the health system overall. And finally, I'd be remiss if I didn't discuss aspects of equity as a component of diagnostic excellence. There are well-recognized disparities in diagnosis, as there are in other patient safety issues. And so an optimal diagnostic system would provide Sorry, just trying to advance the slides here. Okay. So I want to spend a little bit of time talking about CODEX and our role within the diagnostic excellence ecosystem. Sorry, the slides are being a little uncooperative here. Oh, here we go. Okay. So before talking about CODEX, I wanted to spend a minute just talking about the epidemiology of diagnostic error and what we know about the risk for diagnostic error in different clinical settings. So a great deal of foundational work has been done really within, I would say, the last 5 to 10 years to establish the prevalence of diagnostic error and the severity of harm in different clinical settings. So some of the key studies are listed here. But overall, it's estimated that in their lifetime, 1 out of every 20 adults will experience a diagnostic error, either in the inpatient setting or in the outpatient setting. Some recent work done by some of my colleagues at UCSF established that in hospitalized medical patients, 23% of adult patients who experienced a clinical deterioration while hospitalized, that is, patients who died or were transferred to the ICU, actually experienced a missed or delayed diagnosis. And in patients who had a missed or delayed diagnosis while hospitalized, this had significant clinical consequences for them in terms of increasing their risk of severe morbidity or mortality. Diagnostic errors have also been characterized in the emergency department, but there are a few areas in which we don't know as much as we should. Most studies of diagnostic errors have taken place in health systems that are predominantly in urban or suburban areas, so we really don't know that much about diagnostic error, for example, in rural settings. There's a lack of research on the intersection between social determinants of health and diagnostic error, particularly around patients whose primary language is not English. And while there are some good studies around diagnostic error in pediatrics, I would say there's probably less data there than there is in adult patient populations. So I'm going to transition now to talking about CODEX and what our role is within efforts to improve diagnosis. So CODEX was established in 2024 thanks to a generous grant from the Gordon and Betty Moore Foundation. And our mission is to lead change in the field of diagnostic excellence by facilitating activities that result in measurable improvement in diagnostic quality, safety, and equity. And our vision is to transform the healthcare system into one where all patients receive an accurate and timely diagnosis. Our work in CODEX is divided into several domains, which I'll talk about. We view our role within CODEX as partly research, but also supporting the overall field of diagnostic excellence, which definitely includes improving the measurement of diagnostic excellence. So our main goals are listed here. So I'll talk about each of these in a little bit more detail. But a big part of our work involves learning, so disseminating the latest research and innovations in the diagnostic excellence field. In this area, because of the rapid promulgation of artificial intelligence within healthcare, which is increasingly being used as a diagnostic aid, we are centering a lot of our work around assessing the literature, both published and unpublished, around the use of artificial intelligence in improving diagnosis, and trying to make sense of all of the studies which are coming out literally week by week on the use of artificial intelligence in diagnosis in particular. As I said, a big part of our responsibility is to support the diagnostic excellence field as a whole, which involves both capacity building and expanding the field beyond its traditional areas. And then what will be the primary focus of our talk today is on our Action Incubator work. And the Action Incubator, which is the work that Ben has been leading, has the goal of measurably improving diagnosis by bringing together stakeholders to target areas that are ready for diagnostic improvement on a defined timeline. Our three main domains are the Learning Hub, the Engagement Hub, and the Action Incubator. So I'm just going to talk a little bit about each of those before we transition into the measurement-oriented part of the talk. The Learning Hub work is led by our colleague Anjana Sharma, who's a family physician who works with me at San Francisco General Hospital. And our goal here is really to be a source for unbiased information for learning about advances in diagnostic excellence. We put out a weekly digest which summarizes 10 to 12 key studies in the area of diagnosis, particularly focusing, as I said, on artificial intelligence. And this has gotten really good response from our audience, and I think is a great way to stay on top of the latest developments in diagnostic excellence. We also run a monthly webinar series entitled Advances at the Intersection of Diagnosis and Artificial Intelligence, where we try to bring together the informatics community and the patient safety community to discuss the latest applications of AI to improving diagnosis and bring in discussants who are thinking about AI implementation from a variety of perspectives. Here's an example of our digest, which comes out weekly. This QR code will take you to our CODEX website where you can sign up to receive the digest. What we do is we identify 10 to 12 articles per week. They're curated by our expert librarian, who then also writes a brief summary of each article, allowing for understanding of where the article's findings fit into the overall literature around diagnostic excellence. In addition to our learning work, we are also doing as much as we can to support the growing diagnostic excellence field. We run an annual conference, the Diagnostic Excellence Conference, which most recently took place last fall in Ann Arbor, Michigan. And this is an annual thing. We'll be announcing the site for the Diagnostic Excellence 2026 meeting and the dates very shortly, probably within the next week or so. We also are partnering with the National Academies of Medicine to support their forum on advancing diagnostic excellence, as well as their fellowship in diagnostic excellence. And we have an ongoing partnership with Patients for Patient Safety, which is a leading patient-led organization in the patient safety field, who have a strong interest in improving diagnosis and are leading a lot of work around patient engagement, patient advocacy, and measuring patient perspectives on improving diagnosis. So I'm going to turn now to talking about the current state of measurement of diagnostic excellence. So diagnostic excellence and diagnostic error is an area that within patient safety traditionally has had some challenges in terms of measurement. Among these challenges include the lack of diagnostic gold standards. So even for diseases that are quite common, many of them often don't have a single gold standard, either imaging test or blood test, which allows us to definitively say, does the patient have this diagnosis or not? So many things that either Ben and I see in the hospital or are seen in primary care. The final diagnosis is really a combination of objective testing and clinician judgment. And that alone makes it labor intensive, as well as somewhat challenging to establish just the denominator of patients who have a certain diagnosis. Another challenge, which is an ongoing challenge, is the lack of accurate electronic health record data around key aspects of diagnosis. Just as an example, symptom data is not reliably captured within most electronic health records currently. So from a research standpoint and from a quality improvement standpoint, if we don't know exactly what symptoms a patient experienced or when they started experiencing those symptoms, it makes it very difficult for us to be able to judge, was the diagnosis made in a timely fashion, even if we can say, was the final diagnosis accurate? If we don't know when the patient started experiencing symptoms or how characteristic their symptoms were, it's hard for us to say if the diagnosis was made in a timely fashion or in the most efficient fashion. EHR data reliably or fairly reliably includes the patient's actual diagnoses, but often does not. It often takes a fair amount of retrospective work to determine when was the diagnosis actually established and how did the differential diagnosis evolve over time. Another challenge in managing and measuring diagnostic excellence has been a lack of standardized measures of the patient experience as it pertains to diagnosis. So while there's been great progress in measuring patient experience of other patient safety issues, as well as patient engagement overall in the process of care, we are still working on developing both patient-reported outcome measures as well as patient-reported experience measures for diagnostic excellence. As I'll discuss, there has been a good amount of progress in that area, but really, just within the last few years. So those are challenges, I think, that have limited our ability to both measure diagnostic excellence, both on a disease-specific basis, as well as from an overall standpoint. But as I'll discuss, there has been considerable progress made within the last couple of years. So just highlighting on this slide a few of the advances that have been made and of some of the measures that are being implemented both from the federal and non-federal standpoint. So I'm sure there are many people on this call who know more about this than I do, but CMS has implemented a number of both measures and associated with improvement activities to support improving diagnosis over the last few years. Some highlights of these, as many of you no doubt are aware, within the MIPS program, there are improvement activities that center around improving diagnosis that health systems can report. These include improving the diagnosis of cognitive impairment, closing the referral loop between specialists and primary care clinicians, as well as a newer program around reporting measures that organizations are taking to improve the safety of artificial intelligence, which often is being used for diagnostic purposes. And of course, the 2025 MUC list includes 2 diagnostic excellence measures, which I'll discuss in detail a little bit later. From the standpoint of the Agency for Healthcare Research and Quality, as the ARC is undertaking revisions to their quality indicators program, there are actually 14 different measures of diagnostic excellence that are under consideration for incorporation to the next iteration of the ARC QIP program. These are almost all disease-specific measures, but in large part, I think, are derived on advances both in electronic health records as well as the traditional measure development process. And finally, from a non-federal standpoint, the Leapfrog group has added questions to its annual rating surveys to assess what actions hospitals are taking to reduce harm to patients from diagnostic errors. These are focused more on structural measures rather than process or outcome measures. But the fact that Leapfrog has started to include these, I think, highlights the salience of diagnostic errors as a patient safety problem. Many of the advances that have taken place in measuring diagnostic excellence are thanks to investments made by the Gordon and Betty Moore Foundation, who found CODEX and have invested quite a bit in their diagnostic excellence program over the last several years. So Gordon and Betty Moore Foundation had a long-standing diagnostic excellence portfolio, and a good portion of that was focused on funding organizations to develop measures of diagnostic excellence. I'm not going to summarize everything that was done under the Moore Foundation's supervision, but these are some of the highlights of the work that was carried out by organizations that were funded by Moore that have made it through the approval process for quality measures. So as you can see here, there are some measures that have actually been implemented in the MIPS program or included on the MOC list. And there are multiple other measures that have made it through the consensus-based endorsement process, but have not yet been implemented. And so these are programs which, as I said, were funded by the Moore Foundation and over the last several years have been validated and either implemented or endorsed. In addition to these, the American College of Emergency Physicians is in the process of implementing diagnostic utilization measures focused around acute pulmonary embolism. And these are metrics which organizations can choose to report as part of the MIPS program. So while, as I said, measurement of diagnostic excellence is somewhat challenging, there has been a considerable amount of work done over the last several years, in large part thanks to the Moore Foundation, and that has resulted in the development of several measures that are now being widely used to measure various aspects of diagnostic excellence. But that brings us to the current state, which is what has really changed over the last couple of years is the more widespread implementation of artificial intelligence in healthcare and its implications for diagnostic excellence. So AI in various forms, whether it involves machine learning or whether it involves deep neural networks or increasingly the use of large language models, is actually quite widely implemented throughout healthcare. I think it's safe to say that the areas where AI, broadly speaking, is used most commonly are in image-based fields such as radiology and pathology. In radiology in particular, the majority of hospitals in the country are now using at least one AI-based application, and the FDA has approved over 800 different AI-based diagnostic decision support tools focused on improving diagnosis in radiology. So if a patient comes into the hospital and it's suspected that they may be experiencing an acute stroke, more likely than not, when they get a CT scan or when they get an MRI, that scan is being read both by a radiologist as well as by an artificial intelligence application. And the radiologist has the ability to access the AI read of the scan in order to arrive at a final diagnosis of whether or not the patient has had a stroke. And there are similar examples in other image-based fields, as I said, including pathology and dermatology. It's quite common in pathology for slides to receive an AI read in conjunction with the pathologist read, which allows for mutual cross-checking and ideally identification of a more accurate identification of disease processes. So AI has quite a bit of potential benefit for improving diagnosis. The fact that AI is able to access large amounts of data and be trained on gigantic databases across multiple sources definitely allows for the potential to develop both predictive analytics and models to more accurately diagnose common conditions. As AI has progressed, there's increasing interest in the use of large language models to help diagnosis in more common clinical settings. In multiple simulated studies, large language models have actually been shown to have diagnostic capabilities similar to, and in some cases superior to clinicians. Now, I would caution that these studies have not yet been replicated in actual clinical practice, but there's a lot of ongoing research in that area. And in addition to the research that's going on, many of the leading AI companies, as well as electronic health record developers, are in the process of developing decision support systems that are based on AI to help clinicians improve their diagnostic capabilities. Probably the leading example of day-to-day implementation of AI outside of image-based fields are artificial intelligence-based scribes. And some of you may have experienced this just in the course of being a patient or going to a clinician. In many settings, but mainly in the outpatient setting, the implementation of AI scribes is pretty widespread. And this is a technology that really helps clinicians from the standpoint of being able to spend less time just entering data into the computer, allows for a more natural interaction with the patient, and we hope will help optimize the clinician's cognitive load, allow them to focus on the patient rather than on data entry, and hopefully free up time for the more cognitively intensive aspects of being a clinician, including the diagnostic process. So there's a lot of excitement about AI. It's being implemented fairly widely in certain fields, and there's rapid expansion in other clinical areas as well. And a lot of these areas, hopefully it's clear how this impacts diagnosis in image-based fields, but our interest in CODEX is in studying how the implementation of AI broadly affects the diagnostic process, both in terms of benefits and potential unintended consequences. So the unintended consequences of artificial intelligence implementation for diagnosis are listed here. I would highlight cognitive de-skilling, which refers to if clinicians become overly reliant on AI or are trained in an AI world, they may become overly reliant on AI to help them either with diagnosis or treatment plans, which may result in their inability to actually take care of patients if they don't have access to AI. So the issue of cognitive de-skilling is a very real one that is a huge topic in the medical education world. As AI is implemented more broadly, how do we make sure that clinicians, be they physicians, nurses, advanced practice providers, are able to learn core clinical skills without having to rely on AI at all times? And there are other potential unintended consequences as well, including overdiagnosis and overtesting based on how large language models in particular work, which have a great ability to synthesize data, but also may bias towards rarer or more uncommon diagnoses. So as we in CODEX take a step back and think about the diagnostic excellence world as a whole, it's clear that AI is having a big impact and probably will continue to have a big impact for the next several years. And as a result of that, we have spent a lot of time thinking about how we can try and ensure that as AI continues to advance, that it actually achieves the potential that it has. And that is where our Action Incubator work comes in. So I will turn things over to my colleague, Ben Rosner, who has really led our Action Incubator work. And just to give you a highlight of what the Action Incubator is, this is really, as the name says, our action-oriented arm of CODEX. It's through the Action Incubator that we hope to actually achieve measurable improvement in diagnosis by focusing on key areas in diagnosis that either have good measurement strategies or need good measurement strategies and are ripe for improvements on a defined timeline. So we conducted our Action Incubator quite recently and are in the process of our collaborative work that is following the actual in-person meeting. So let me turn things over to Ben, who will take us through our ongoing work. And then after that, we'll definitely have time for questions and reaction.
Thank you, Sumant. And feel free to move to the next slide. As Sumant had mentioned earlier, the goal of the Action Incubator is really to try to amplify research by translating it into tangible next steps. And the idea with CODEX for an Action Incubator is not a one-off. In fact, we are interested in having recurring Action Incubators. We bring together people in the area to try to then move things into actionable next steps. And as Sumant mentioned, we held our first one this past September, and I'll share with you a little bit about how we developed the model for what it is, what our thought process is, and also at least where this first Action Incubator is heading before we think about where the future ones will move as well. So if you can advance to the next slide, please. As we thought about some of the models for what is an Action Incubator and what is, in essence, the optimal way to carry one of these out, we spent time doing a landscape review to try to examine, are there other examples of successful action incubators that are trying to translate, in essence, research and concept into action? There are a few examples that have been done before, but none really specifically to diagnosis. However, some of these models did give us ideas for approaches for best practice. So, for example, we interviewed approximately 20 thought leaders from around the country and asked them questions such as, what is in your opinion, a good or optimal product of an action incubator? Is this a white paper, or is this a research article, or is this putting things into implementation in health systems, for example? We also asked them, what is the optimal size of an action incubator? How many people should be involved? You can imagine there might be a sweet spot where you have enough stakeholders involved, where you have a variety and breadth of concepts and ideas, but you don't dilute that experience by too many people where your engagement drops off. So after interviews with about 20 national thought leaders, we started to center around the concept of an in-person action incubator, 1 to 2 days, and limited to approximately 30 to 35 participants so that there would be high engagement and participation. And in so doing, we also recognized that there was actually quite a bit of a need for some diversity in approach. You don't want to just bring those to the table who are in, let's say, only research, or those to the table who are only patient safety, and also those to the table who are only from 1 or 2 industries. We actually came to learn a great diversity of stakeholders was actually necessary to move something like this forward. If you could go to the next slide, please, Sumant. So we spent a good bit of time, as you can see here, in advance of the Action Incubator, developing the model with the idea then of bringing all of these stakeholders together in an in-person meeting. We held this first one this past September, and that in-person meeting really sort of sets the stage for quite a bit of homework to do afterwards. We're in that process right now, which is sort of to develop this actionable measurement framework. And I will say one of the interesting challenges in thinking about that when you are trying to develop something that can represent a diversity of interests and stakeholders is how to approach something that will generalize across many different healthcare settings and across many different stakeholders in a way that will be meaningful. And at the conclusion then of developing this framework, then the idea is to bring that framework out into the real world, into health systems, and measure the actual impact for diagnostic excellence. If you could go to the next slide. So we wanted to bring to the table the concept of how do we measure diagnostic excellence in the context of artificial intelligence. Now, I mentioned first a diversity of stakeholders. So we had about 30 or so stakeholders from across the country that represented really a broad landscape of participants. These included members from industry. We actually had folks from the AI scribe industry present, from insurance, medical malpractice. We had representatives from 11 health systems participating. The health systems are actually where this deployment would actually happen. So you can imagine the Action Incubator being the source of idea generation and collaboration with the ultimate goal of deploying something that can be measured across these health systems. Now, I'll say that it was important to us that these health systems represented as broad a swath as possible. So we had a split between academic medical centers as well as community health systems, as well as safety net hospitals, in order to try to capture that breadth of experience. We also made sure that we had patient advocacy organizations present at the table, as well as a couple of payers, one of which was a federal payer. the way that we brought this group together was to really sit down in the same room together, but we actually had a facilitator organizing the discussion, sort of setting the ground rules. You can imagine when you put 30 or so experts into a room together, you may end up with 40 opinions and lots of people eager to participate. Fortunately, there was a lot of eagerness to participate and a lot of great ideas that came to the table, but the facilitator sort of helped manage all that so that we would have some very discrete and actionable outcomes at the end of this in-person meeting that sort of set the blueprint for how to move forward in the months that followed. We started the Action Incubator actually with a presentation from an expert in AI and radiology, because we felt that there are a lot of lessons that could be learned with radiology's experience with AI, since it's been a leader in that area ahead of many other specialties. So we had expert presentations, but we also had breakout sessions where representatives sort of dove in more deeply into specific use cases and settings, including how do we think about diagnostic excellence using AI in ambulatory emergency department, acute care settings, et cetera. And then we had those groups share out some of their approaches and learnings. Next slide, please. Now, one of the interesting challenges as you think about, well, how is AI available or deployed in a very broad setting? Right now, as Sumant mentioned, the most broad use case of AI in healthcare is actually AI scribes. Now, traditionally, AI scribes are really not meant for diagnostic purposes. They're meant for documentation. But because they're widely deployed, we thought it might be interesting to look at how is the use of AI scribes potentially influencing diagnostic excellence. We refer to this as the current state of AI deployment. Now, in the interim, since we had our Action Incubator meeting, things are moving towards what we refer to as the future state of AI implementation. That future state really is one in which AI is deeply embedded into the electronic health record so that clinicians can have, for example, conversational queries that are context aware of the patient. You can imagine in this future state where which is emerging, and some health systems have this now, where clinicians might ask for differential diagnoses in a context-aware manner in which the artificial intelligence knows a lot about the patient because it's able to access the full medical record. But in the current state, in the use of ambient AI scribes, one of the things that we posited was, well, does the use of ambient AI scribes in any way have an impact on cognitive load or cognitive burden? In the early days of this Action Incubator, the literature had not yet sort of landed on an answer to that, but it does appear increasingly that there is a reduction in cognitive load when clinicians are using AI scribes. And so the question is, does that give them cognitive space to be better diagnosticians? And if so, how should we measure that? So we know that with this increasing adoption of AI scribes, increasingly clinicians are using them, and also there's the potential for patients then to have input on their thoughts as to their diagnostic experience when the clinician may be looking at them eye to eye in the encounter rather than tethered to a keyboard. Next slide, please. So there's an interesting ARC issue brief, which in fact supports this, this notion that cognitive load itself is an independent variable that can affect diagnostic excellence and should be accounted for when designing clinician workforce structures. So the way that our Action Incubator thought about landing on this was, let's look at some kind of measures of diagnostic excellence in two contexts. One in traditional care, the image on the left, where the clinician is in fact at that keyboard and documenting during the encounter, versus the one on the right, where the clinician is freed from that keyboard and is using an AI scribe to do the documentation. Next slide, please. And so then our group turned to, well, what is it that we ought to measure? And this This discussion really, in essence, was a modified Delphi panel where we proposed a variety of potential candidate metrics to measure. And then as a group, we would vote on them and try to come to consensus on what would make most sense. So since the in-person meeting, we have hosted now a number of synchronous webinars or remote meetings where we discussed candidate metrics. The idea behind the metrics is to potentially have as broad an impact as possible, but in certain important areas. Now, one of the challenges, as Sumant has mentioned, is that it's very difficult to have a purely generalizable measure of diagnostic excellence. In fact, we find ourselves, because of the variability of diagnosis, condition or disease by disease, we find ourselves, in fact, gravitationally pulled towards thinking about how to measure diagnostic excellence more on a disease by disease basis. But if we can select diseases that have large numbers of patients and very meaningful potential outcomes, that could be then very important as a proof of concept in moving this forward. Next slide, please. So where we have landed with our Action Incubator participants was the notion of looking at follow-up on abnormal test results. In particular, we landed on ARC's quality indicators for timely follow-up on abnormal stool tests for colorectal cancer and abnormal mammography tests for the detection of breast cancer. We chose these in particular because there are very well-defined actions that can be measured on the back end in the electronic health record. Did a clinician take the appropriate action? For example, following an abnormal screening FIT test, did they order a colonoscopy? That can readily be queried for in the electronic health record, so it's easy to measure if that action was taken. And the same approach for abnormal mammograms. So after landing on those two, because they do actually have substantial impact on a large population, we also wanted to make sure that we were capturing the patient experience of diagnostic excellence and what their perception of diagnostic excellence might be in the context of when a clinician uses a scribe versus when they do not. And we're still in the process of identifying what are appropriate questions to ask patients of that diagnostic experience. Last, as I mentioned, we are looking towards this future state when AI is deeply embedded into the EHR. There are a number of health systems in which this is already available, but realistically, in the next year, we will see this much more broadly available, where most of our participating health systems will have access to these sorts of tools, not only because vendors are developing them, but also EHR vendors themselves are increasingly making these tools available in the electronic health record. And then we will be able to look at a whole host of very interesting opportunities to measure diagnostic excellence, looking at, in what way are e-triggers, which has traditionally required human adjudication, but could LLMs do some of that adjudication for e-triggers, looking at whether LLMs can be used to assess the quality of diagnostic decision-making, or even something as simple as purely just measuring the proportion of time that the clinician spends listening to the patient, which we know has an important effect on their potential performance as a diagnostician. Next slide, please. So with that wraps up the Action Incubator discussion and most of our presentation here. Sumant, if you would like to say anything else to wrap up, feel free. Otherwise, I think at this point we are interested in opening up the floor for Q&A.
So much, Sumant and Ben, for a wonderful presentation. And thanks to everyone who submitted questions. It's been a really great discussion. Thank you all for taking the time to join today's MMS information session. We really appreciate you spending the afternoon with us. We can go to the next slide. So as we close out, we just want to share that CMS will be hosting their annual quality conference March 16th through the 18th in Baltimore, Maryland. The theme for this year's session is Make America Healthy Again, Innovating Together for Better Health. We encourage you to visit cmsqualcon.com to register for this wonderful opportunity. We can go to the next slide. And as always, we encourage you to visit the MMS Hub, which is your trusted source for quality measures and quality measure development and maintenance information. You can find all updates on news and events that are happening in the quality measurement community, such as if you go there right now, you'll see that there's currently a public comment period open for the draft CMS Fire DQMs, which closes on February 23rd. And then lastly, if we go to the next slide, we also keep you updated on ways to get involved. There are currently open opportunities available for you to nominate yourself or others to technical expert panels for 2 measures. So visit the MMS Hub website for more information on how to get involved in those opportunities. And with that, I just want to thank you again for taking the time to join us today. We look forward to speaking with you again soon. And if you go to that last slide, if you have any questions, feel free to reach out to us at mmssupport@battelle.org, and we would be happy to assist. Thank you again for coming today. Have a great rest of the week.